we're talking about psychosocial and medical ethics of informed consent, because when you talk about hormones, it's not just about prescribing the hormones. There's a whole context to that. So I will talk a bit about transgender and gender diverse people's experiences of accessing healthcare, a patient-centered approach, and then I'm going to give some highlights from Standards of Care 8. We were fortunate to be able to attend the WPATH symposium online. So I've got some information from that, and then Sakhile will continue with the ethics guidelines and informed consent. So we know that transgender and gender diverse people face social exclusion, stigma, discrimination, violence, and ignorance from us as health professionals. This happens in a societal context of heteronormativity and cisnormativity where there's little space for people who are different. And this then leads to health disparities, as already pointed out by Ron in the previous talk. And Ron also mentioned intersectionality, where gender might not be the only area where somebody is discriminated against. If you go around this wheel, there's citizenship, skin color, formal education, ability, one's sexuality, neurodiversity, mental health, body size, housing, wealth, language. There's so many different aspects in which people can be discriminated against and which can then make people's lives very, very hard. Ron mentioned the study that was done to look at violence, mental health, and access to healthcare for sexual orientation and gender identity. And of the South African participants, I think he mentioned this one already, that people reported being treated with less respect, being insulted and denied healthcare. We have more recent data as well from the Richitsi Key Pops report, where 45% of the trans respondents said unfriendly services is the reason they do not access healthcare at all. So in a context where we want to provide gender-affirming care and be able to prescribe hormones, we need to get people to come to us. And if they have such bad experiences that they don't want to come, that's a real challenge. So we have an ethical duty. So WHO talks about person-centered care that embodies an approach that adopts the perspectives of individuals, families, and communities. So it's not only what we as healthcare workers think, but the perspectives of the people who need our care. It respects and responds to their needs, values, and preferences, and see them as participants in their own healthcare. And Ron already referred to the participatory approach. And this then comes out very clearly in Standards of Care 8 as well. And we're delighted that this has been published. So from Standards of Care 8, the autonomy of the transgender or gender diverse person is enhanced and centralized. Clinical assessment remains an important element. So the idea is before you provide care, you want to know the person. So it's getting to know the person. That's the clinical assessment. There's a big emphasis in Standards of Care 8 that these are global guidelines to be used in different health settings. So it does set a very high standard, but there's an awareness that there's differences globally and can be adapted according to local need. And the guidelines further recognize the diversity of gender. As Ron explained, it's not only a binary. There's a lot more. There's a galaxy. So some differences between Standard of Care 7 and 8. The first one is the name that is different, that it's no longer transsexual, transgender, and gender non-conforming, but now the health of transgender and gender diverse people. And for surgery, genital surgery, 2 referrals were needed. Now a single opinion is needed for all surgeries. The assessment must be conducted by a qualified mental health professional, as what Standards of Care 7 said. And now there's a different understanding that it must be somebody who has competence to identify gender incongruence and can identify things that might look like gender incongruence, but might be something different, requiring treatment. And it must be somebody who can support the person through the process. So it's not as strict in it can only be a mental health professional. It can be somebody who has the competence, who's a health professional. Then there was this thing of having lived in the gender role that's congruent with their gender identity before genital surgery. And now there's no specific requirement to live in role. Social transition should be considered and discussed, but there's no requirement anymore. And then if, this was one that was hotly debated. If significant medical or mental health concerns are present, they must be reasonably well controlled, was one of the criteria for accessing hormones or surgery. And to know what is reasonably well controlled was a very difficult thing that people were very concerned that it might lead to gatekeeping. So in the new guidelines, it says, any physical health conditions or mental health conditions that could negatively impact the outcome of gender-affirming medical treatments are assessed with risks and benefits discussed before a decision is made. So it's this collaborative approach. So if somebody would come and they have existing things that might be influenced by the hormones, we need to have that discussion. But we're not going to say your blood pressure needs to be perfectly normal before I'm going to start you on hormones. Then there was this thing of hormone treatment before surgery. And now it is still hormones recommended, especially before gonadectomy. So, but they say when hormones indicated and chosen by the transgender and gender diverse person. So there might be non-binary people who may want some surgery, but may not want to take hormones. And then that is a conversation, and they can still access care. Then there was in version 7 separate guidance for the different surgery types. And in version 8, surgery types are not differentiated. And then there's a new section in version 8 for specific guidance on detransition and regret. We know that it's very rare, but it is a thing. So there are some things written in standards of care about that. Then the criteria for hormones in standard of care 8 is that the first one is that gender incongruence is marked and sustained. So it's not somebody who woke up yesterday and comes today, but well, one wants to know that this is something that has been there for some time. Meets diagnostic criteria for gender incongruence prior to gender-affirming hormone treatment in regions where a diagnosis is necessary to access care. Now, this is a very interesting way that it was phrased to account for a global guideline, because there are places where for the medical aid or healthcare to pay for your treatment, you need a diagnosis. Okay, so that's where the diagnostic criteria come in. For the South African guidelines, we said there must be gender incongruence and then other criteria, but we didn't include diagnostic criteria. Then the next one is demonstrates capacity to consent. And then they specifically brought in understanding the effect on reproduction and have explored reproductive options prior to starting hormones. And then other possible causes of apparent gender incongruence have been identified and excluded. It's very rare, but it is important to look at that. And then mental health and physical conditions that could negatively impact the outcome of the treatment have been assessed with risks and benefits discussed. Once again, it's not gatekeeping, it is discussing the risks and benefits with the trans and gender diverse person in a collaborative way so that there is informed consent. And then there was this very interesting thing that they have found an increased cardiovascular risk in both trans men and trans women compared to the general population. And they were investigating, is this due to hormones? And actually, it's due to minority stress. So Ron already showed you the minority stress model where there's internalized stigma, there's the microsystem and the mesosystem with interpersonal stigma that is enacted or perceived, and there's the macrosystem with structural stigma. All these things can impact on somebody's mental health and cause a physiological and psychological stress response. So there's cardiovascular risk factors that are psychosocial, like depression, anxiety, stigmatization. Then there's behavioral risk factors, diet, physical activity, sedentary behavior, alcohol use, smoking, and sleep. And some of those are in response to the psychosocial risk factors. And then there's the clinical risk factors like hypertension, obesity, cholesterol problems, etc. And all these things work together to increase the cardiovascular risk. And that I found very interesting, that we now understand that minority stress can actually influence the cardiovascular risk, that the hormones itself are very safe, but that there's other factors that play a role. And that is all I'm going to say. So I'm going to hand over to Sakhile.
Thank you so much, Elma, for that. I'm going to quickly just share screen. So trying to figure how to do that. And okay.
Oh, we can see your screen.
Okay,
there we go. Cool.
Thank you so much. Apologies, everyone. You'll not be able to see my beautiful face due to load shedding. And so I have to do this on my phone, which is really testament to the work that we do when we're providing gender-affirming services, that a lot of it is about reacting to current needs of clients and working within limiting contexts. So thank you, Elma, so much for that. I might worry you a bit about the power wheel again. I might want to revisit it as I talk about it, because as you were speaking about intersectionality and why we need to pay attention to it, you really sparked an idea that I would like to follow up on a bit later in this particular talk. So we'll be looking at ethical guidelines that are outlined by the HPCSA. We know that for all registered healthcare professionals, we do have a set of core ethical values that we must uphold in our practice to maintain good professional practice. And being registered as a healthcare professional with HPCSA confers on us the right and the privilege to practice our professions. This then sort of pushes us again into that space where there is potential for gatekeeping, like Elma was saying, but I'm going to unpack this a bit more, especially when you're looking at that word that says privilege, right, to practice. Correspondingly, practitioners have moral and ethical duties to others and society. These duties are in line with the South African Constitution. So I think, just as a reminder to everyone in this particular talk, we need to always be aware of the fact that our practice needs to be ethical, and HPCSA has set out these core guidelines. Oftentimes, when it comes to gender-affirming health care, we wait for people to develop an interest in order to provide services, where there's a sense that if this is life-saving for someone and you're denying them services, isn't that breaking an ethical principle? And isn't that going against what we have signed up for as health professionals in and of itself? And also as being part of working within South Africa and being guided by the South African Constitution, are we not sort of taking away and breaking some of those human rights? So these are some of the core ethical values and standards that we'll be looking at: respect for persons, non-maleficence, beneficence, human rights, autonomy, integrity, truthfulness, confidentiality, tolerance, justice, professional competence, and self-improvement, and community. Not in this order, but those are some of the things that I will touch on as we go. Why do we need to pay attention to ethical practice? particularly in our context. And Ron and Elma have touched on this, and Ron referenced the Muller 2019 study, which for us highlights the sort of mental health care related issues that trans and gender diverse and non-binary folk face. Because of, as Ron sort of highlighted, the histories of our country, but not just our country, also just at an international level when we're looking at queer and transphobia, where we're looking at how sort of the landscape has changed in how we understand sexuality and gender diversity. And so we know in South Africa, there's a lot of human rights violations, right? Where with recent and ongoing killings of queer folks in different contexts. And so, you know, and we know that there's challenges with access to healthcare for queer persons in general sort of settings, which again speaks to intersectionality, which we'll get to in a moment. We know that trans and gender diverse and non-binary folk and queer folks in general face multiple traumas and vulnerabilities across different spheres of their lives. So if for anything, our role really is to, in a participatory way, aid in alleviating or working against that minority stress disorder that we've been touching on today. So the first ethical principle that we are touching on is the principle for respect for persons. Healthcare practitioners should respect patients as persons and acknowledge their intrinsic worth, dignity, and sense of value. And this is very important because oftentimes, because of that power dynamic, right, that is oftentimes felt by clients or patients, depending on the language that that one is comfortable with, you know, there's always that sense that I'm coming to a person looking to alleviate whatever sort of tensions I'm dealing with, but I'm getting a sense that my dignity and my sense of worth is being questioned. And this happens within institutions. From the moment a trans or gender diverse person enters the gate by the securities, all the way to registrations when they have to get their files recorded, and you know, and sometimes even to when they're sitting in the consultation room with the healthcare professional. So to be affirming, we need to also acknowledge the challenges that our trans and gender diverse persons face at multiple levels when they come into our institutions, and query about that and speak about that, and just acknowledge the challenges that they may have faced, and explore possible triggers along the way. So the standard of general respect includes respect for the rights, knowledges, and experiences of others, refraining from engaging in degrading comments in public or even in private or in practice, the use of language that conveys respect for dignity of persons. Language considerations are particularly relevant in the work with transgender individuals, because we don't want to do harm. And I will touch on this a bit later on. I saw when Ron was presenting in his slides, there was mention of dead names, there was mention of given names and pronouns, right? And so we need to be quite sensitive. If we are respecting a person, you need to respect them holistically. And part of that is very much linked into the language that we use as healthcare professionals. We need to, even in our writing, when we're making our referrals, refer to clients with their pronouns, right? And you can already see what Ron was talking about, where in this particular slide, I've written preferred pronouns, but ideologically, we know that we are sort of moving away from that. And part of the service that we're providing and working in the space of gender-affirming healthcare is opening yourself up to learning, is saying, this needs to change. This about my practice needs to change. I need to move along with the times. And it's part of just that self-development as a practitioner as well. So when we get to our next sort of ethical principle, which is around human rights and the protection of vulnerable persons, healthcare practitioners should recognize the human rights of all individuals, right? A healthcare professional holds a position of power, as I've sort of alluded to, as a service provider, particularly in the case of psychosocial assessment for gender-affirming healthcare services and hormone therapy, where their recommendations may create a gatekeeping role. Several considerations emerge in the assessment of capacity to consent for a transgender individual when gender dysphoria or gender incongruence occurs in the context of intellectual disability. Transgender individuals may not have the capacity to give informed consent and may not fully comprehend the cause and consequence. And this is what Elma was sort of speaking to, where we need to be very sensitive in how we navigate space, where certain disabilities do not preclude a person from being able to access gender-affirming healthcare, but we need to be aware of them and navigate them in a participatory way with the person involved. So we're going to move to autonomy, beneficence, justice, and non-maleficence. When we're talking about autonomy, what are we talking about? I'm sure all of us sort of know this. A healthcare practitioner should honor the rights of the patient to be self-determination or to make their own informed choices, to live their lives by their own beliefs, values, and preferences. This is also linked very much with what Ron was talking about earlier on when he was saying, how do you know a person's gender identity? By asking. It seems quite simple, but oftentimes a lot of healthcare providers and practitioners, we struggle with that. And again, I suppose part of it comes from socialization and the social scripts that people draw from that sort of makes us believe that we can be experts over other people's bodies in terms of just being able to identify their gender without consultation. And we are saying today, you know, the ethical principle of autonomy sort of it asks us to, you know, respect and honor the patient's self-determination and their ability to make their own informed choices. So the notion of self-determination refers to individuals' right to have control over their own lives and to make their own decisions. The very requirement of mental health care referrals for gender-affirming services contradicts the transgender person's autonomy to modify their own body and to align themselves with how they identify. So we query, how then do we navigate this possible gatekeeping? And we're hoping as we go on today, that's something that we're going to talk to at a later point. So what does respect for autonomy look touches on? It touches on issues of informed consent, confidentiality, truth-telling and not deceiving our patients, and communicate open and ongoing communication, and our ability to listen to our clients and their needs. So Anastasia Thompson speaks very much in depth about the issue of gatekeeping and versus informed consent in the article published in 2018. And I'm going to be touching on some of the aspects of what is highlighted there as I continue engaging with these ethical principles. So let us talk about informed consent. Informed consent is the result of a collaborative process between the healthcare professional and the client, including full disclosure of all components of testing and the integration of options and wishes of the client as much as possible. Furthermore, since most of the assessments are not an end in and of themselves, but are instrumental in ultimately receiving gender-affirming health affirming health services, clients should be reminded that their right to withdraw or refrain from any psychological or medical assessments at any time without penalty. With informed consent, because the duty is on the healthcare provider to provide all the necessary information, to provide in as much detail and to explore in a collaborative way with our clients what their unique needs may be. This empowers the individual by upholding their autonomy. The client and the healthcare provider are collaborative partners in the decision-making process. Healthcare providers informs the client of the risk and the benefits of treatment, enabling them to make an informed decision about how their journey is going to look. So as part of informed consent, we also need to talk about issues of confidentiality. And in gender-affirming services, there's an understanding that we work as multiple disciplinary teams where you have different aspects working on different components together with the client. And so you would have a psychologist, a sexologist looking at something slightly different, social workers, you'll have medical doctors, you'll have speech therapists, you'll have surgeons. And so when you have this multidisciplinary team, the ethical principle of confidentiality needs to be discussed with the client, and the limits to such confidentiality where sensitive information about their journey is going to be shared with other professionals. And again, there needs to be explicit permission provided by the client for us to be able to share those confidential information with our colleagues working together with us. So the sort of next ethical principle there is the principle of beneficence. Healthcare practitioners are professionally obliged to provide the best possible service to maximize client benefits. This obligation includes the selection of optimal assessments and investigation, the coordination of care with other healthcare providers, and awareness and utilization of the knowledge and skills of other disciplines. This is why in this space, and even in Part SA, we have different sort of professionals together in one space, because there's a sense that we all need to know and share knowledges about the different stages that our clients will be walking as they continue in their gender affirming journeys. And so it is important that we are able to collaborate in ways that perhaps other forms of medicine are not necessarily speaking to at this point in time. By respecting and validating and affirming the patient's identity and their rights to make their own decisions regarding their healthcare and treatment, we are directly improving the outcomes for patients. There are numerous studies, as argued by Thompson in 2018, that there's numerous studies shown to improve the quality of life and outcomes for transgender patients following hormone therapy and surgery. And I think Ron also touched on this when we were looking at that Mueller study around issues of mental health care challenges and suicidality that is faced by trans and gender diverse and non-binary and queer folk. That is reported and is alarming, that is reported in the 2019 Mueller study. So the ethical principle of non-maleficence, first, do no harm. And so we are required to provide, from beneficence, to provide the best possible standards of care or services. And because this next ethical principle says do no harm, the standard is to minimize harms, enjoins health professionals to refrain from activities that bring harm to their clients, such as taking advantage of power relations or placing their clients at risk. It is the case that gender-affirming services can potentially cause harm to clients, including psychological risk and physical risk and risk of regret. This is what Elma was touching on when we have to acknowledge, I think Elma was saying that it's acknowledged in the SOC 8 that there's a possibility of regret of the the affirming journey, and that is something that we need to speak to when we are collaborating with our clients very on. You know, and I often say that oftentimes when we think about or the anxiety for most healthcare professionals around this issue of regrets is that what happens if someone regrets their journey. But it is not, this issue is not just unique to gender affirming healthcare. This issue is inherent in any sort of healthcare practices. If you're thinking about clients that undergo chemotherapy and their quality of life sort of declined, and they say, or some may say, I regret having started chemo because at least I had a better quality of life. So if the ethical principle for us is speaks to being able to talk about the pros and the cons of the services that we're providing, and allowing the person to make their informed decision around that. Again, not gatekeeping because of our own anxieties and projections towards our client. Again, that those collaborative efforts and working together with the client might help mitigate any sort of form of risk there. And Thompson 2018 argues that since the access to medical transitioning improves outcomes, particularly around suicidal risk for transgender patients, limiting access to these interventions can be seen as harmful in and of itself, and such as a violation of the principle for non-maleficence. And at a social level, at a psychosocial level, when you think about not doing harm, we have to think about what withholding services may do to people. If you're thinking about a trans feminine person in a community where they could be clogged, and by that I mean where other community members may be able to identify that they're a trans identifying person, the social risk inherent in that is something that one needs to think about. And perhaps, you know, if people are allowed to access healthcare, then those social risks in and of themselves are sort of decreased. So there's the ethical issue of justice, where which is slightly, it's multi-layered. There's legal justice, the rights to self-determination, that is linked to the ability to go and be able to change a gender marker on your IDs, rights based on justice, which is respect for persons' rights, human rights abuses, which I've sort of touched on earlier on when we were talking about our context. The concept of distributive justice implies that all individuals are entitled to benefit equally from the contributions of the field and services provided by healthcare professionals, regardless of any personal characteristic or status. Issues of access to gender-affirming healthcare services is an obstacle to distributive justice. We know that there's lack of specialized services in our country. We know that there's long waiting lists where services are in essence available, but people still need to spend years waiting to be able to access some of our gender affirming healthcare services. So in and of itself, that is quite problematic. So just to take a bit, when we're talking about justice, we need to also reconsider the issue of intersectionality, where intersectionality is the interaction of different axes of identity, such as gender, race, sexual orientation, ability, socioeconomic status, in multiple and intersecting ways, resulting in different forms of oppression that may be affecting a person in interrelated ways. What intersectionality as a lens says to us is that through this lens, you can see where power comes and collides, where it locks and intersects. It is the acknowledgement that everyone has their own unique experiences of discrimination and privilege. Elma showed earlier on that wheel of power, and at the center of that wheel is where power is said to reside. So I'm not going to ask now Elma to put it up again because this is recorded and we can always revisit that part of the presentation. But what that wheel of power sort of speaks to is that the further away one is from the center of the wheel, the sort of more marginalized they may be. And so, for instance, a person who may be abled may have more power than a person who has some disability. And part of that thinking is that heterosexual people, by virtue of us living in very heteronormative communities, have more power than, say, persons with sexualities that are regarded as minority. And so it is very important when we're engaging with each and every one of our clients to locate these interlocking intersections that may inevitably place a level of oppression on them as persons, and may also then provide us with certain elements of privileges that we need to acknowledge within that space so as to make the space as affirming as possible for our clients. So this sort of ethical principle speaks more directly to us as healthcare providers, that this is the professional competency and self-improvement. The standard of competency and self-knowledge requires the healthcare professionals only to offer or carry out activities for which they have established competency, not to delegate tasks to other professionals without the same competencies, and to seek consultation and addressing issues beyond their own competencies. This is where collaboration is important. This is where these sort of trainings become important, that we, as the previous speakers have been saying since we started, that this area of work is constantly evolving. There's constantly a change of terms, and we are all sort of being asked to keep up to date with the latest sort of developments in the workspace that we do, with the recent release of SOC 8, with our South African HIV Clinicians Society guidelines that came out last year. All of this is really speaking to this sort of professional competency and self-improvement that we need to recognize and acknowledge and be part of. Truthfulness as a standard, it speaks to the accuracy and the honesty that that we need to, at all points when speaking to clients and our colleagues, just be honest about our limitations in terms of scope of practice. Just be honest about our limitation in terms of current knowledge, and the fact that maybe one might need to actually go and read up on certain aspects of gender-affirming healthcare, or refer to other professionals or colleagues who have expertise in a set area from which we are working. So then there's a standard of objectivity and lack of bias. Healthcare professionals must consider how their personal experiences, attitudes, values, and training may influence their thoughts and actions, and strive to be as objective and unbiased as possible. Make sure that their professional beliefs do not produce their patients' health beliefs that might produce or care related to patients' race, culture, ethnicity, social status, lifestyle, perceived economic worth, age, gender, disability, communicable disease status, sexual orientation, religions, or spiritual beliefs, or any conditions. So it's speaking to that intersectionality and the positions that we hold as professionals in relation to our client. And we're saying, if you're respecting their human rights, and if you have that respect for persons, if you hold that first sort of ethical principle that I spoke about, you should be at a space where you are able to better navigate your own sort of attitudes and values, because those should not interfere in the provision of care for our clients. And if you really feel that your beliefs might affect the treatment they provide, they must explain this to patients and inform them of their rights to see other healthcare practitioners, because we are trying to run away from doing harm. If really, your beliefs and attitudes have the possibility of affecting how you provide treatment to persons, best you be honest about this and you refer them to other practitioners that are better able, or that are more sensitive to dealing with the issues that we're talking about related to trans and gender diverse and non-binary folk. So in terms of the standard, when it comes to community, the standard to develop knowledge requires healthcare professionals to contribute to the field of expertise, to refrain from interference with open transmission of ideas and information, and stay informed of process. So this sort of standard requires us to constantly be active and not just consumers of new developments coming from the first world countries, but also to produce and acknowledge the knowledge base that we have as practitioners working in our context, and to publish such works, because it's beautiful to see that the rest of the world is catching up to our thinking as South Africa. As evident in the SOG 8, how similar it is to our South African HIV Clinicians Society guidelines. This speaks to just the acknowledgement of our own contribution in country, in context from which we are working. And we are saying that these knowledges and lived experience of our practitioners and our clients and civil society need to be acknowledged, because then they improve the quality of services that we are able to provide as healthcare providers. For psychologists in particular, the standard development of society requires psychologists to work to the benefits of society as a whole, and to object the use of psychological findings in ways that harm groups and individuals. Psychologists should be aware of current social and political climates to prevent misinterpretation and misuse of psychological findings. Mental health care professionals should work towards the reduction of stigma and discrimination of transgender individuals across different spheres in education, healthcare sector, housing, and employment. And I think this particularly applies to all healthcare professionals providing gender-affirming healthcare, that it is really part of our duty to work to dismantle that stigma and discrimination that a lot of our clients are sort of facing on their day-to-day experiences. So there are pathways of creating affirming spaces. And this is like I sort of alluded to earlier on, where I said a number of, and Elma, I think, touched on this earlier on, to say that studies have shown that a lot of our trans and gender diverse clients don't access healthcare because there's insensitivities and re-traumatizations and triggers that happen when they enter into institutions of health. And if we are talking ethics, we know that this should not be happening, because this is a violation of their human rights to access to healthcare, as stipulated in our constitution. So pathways of just creating these affirming spaces is just to ensure that the staff in our institutions are sensitized to issues of gender diversity and diversity of sexuality, that really in our working in our institutions, that we adopt this idea of gender galaxies. I quite enjoyed that, as it aids and helps us to better navigate the burden of the binaries. So just to ensure that from the moment a client enters the gate, there is sensitivity there. The moment when they're opening up a hospital file, for example, there's sensitivity, and because affirmation is a process and it's holistic. we can't just say that we are providing affirming spaces when we're only referring to ourselves in our private consultation rooms. It's about thinking around issues of toilet space within institutions, and identification markers, gender identification markers that are used within these institutions. So creating a welcoming physical environment, again, gender neutral toilets, administrative purposes that are affirmative, that seek to affirm the person. And remember, when we talk about these things, it sounds, some people say it sounds like a daunting process. And from what we've been saying today, just ask the individual about how they want to be referred to, how they identify. It is really as simple as just asking one question or one or two questions in a respectable way, and allowing the person to self-identify. But for some reason, it seems people really struggle with wrapping their heads around that. So the use of language is very important when taking sexual history. Again, just because a person has indicated their gender identity, it does not mean you know about their sexuality. Again, when it comes to that, do ask about sexuality. Like Ron was saying, that gender and sexuality are sort of separate concepts. And for us working in rural contexts, it does at times take a level of psychoeducation and exploration, because maybe in terms of indigenous language, there isn't a clear distinction between the two. And so we are sort of in positions where we have to figure out with our clients what it means for them and how they view these sort of two separate concepts and how they interact for them, so that the language that we use within our space is sensitive. And just for all our healthcare providers to be sensitive throughout all the examination processes that take place. And part of being sensitive to examinations is explaining to the client why certain questions, why we would need answers to certain questions, explaining why certain examinations are important, and reframing from doing examinations that are not absolutely necessary for the process for a particular client. So that brings me to the end of my particular presentation, and I want to end it off by just saying we need to always be mindful of our ethics. We don't really have a choice when it comes to it, and oftentimes we think we do after we've written our board exams and we've passed and we've qualified. But we need to be sensitive to this because they're closely linked to our constitution, and you don't want to be in positions where you are breaking other people's human rights. We need to acknowledge also as healthcare professionals that this is a growing field, that there's going to be teachable moments for us, and be open to, like Ron was saying earlier on, to being called out and to learning, to figuring out the local language that is being used in context by our queer, transgender, diverse, and non-binary folk. This is one space where we need to be as knowledgeable as possible, but also open to being led by our clients. And we need to be aware of our own intersectionalities. Oftentimes, healthcare providers might project their own anxieties and insecurities on clients, and also just be mindful and acknowledge the resilience that most of our trans and gender diverse folk have. And because of their lived experiences, they know how to navigate space, they know how to navigate the challenges that are presented to to them by life. And so we need to acknowledge that and also help them, aid them to be aware of the power that they possess and the abilities that they possess. And it is in us sort of dismantling those power privileges in our working with trans and gender diverse persons that we and working collaboratively with them, that those sort of the resilience is acknowledged, and their local knowledge and their lived experiences is acknowledged as well. So thank you for listening. I think that brings me to the end of this particular talk.